This year I'm giving a series of lectures on heart disease, and this is the third of 3 lectures. The first one considered problems of the coronary arteries and myocardial ischemia, where the heart is short of oxygen, very common cause of heart disease. The second one considered rhythm problems, the heart going too fast or too slowly. And in this talk, I'm going to consider the third large group of things, which is issues from the muscle, from the valves and the covering of the heart, the structures of the heart, which can be damaged and can therefore lead to heart disease. Now, around the time that Gresham College was founded in 1597, there was a big change occurring in the understanding of the structures of the heart. There had been already a lot of people had studied the physical structures, and those are really quite well understood. And I've illustrated this with, on the left, a very famous book of anatomy that was produced in the 1540s. But the big change in our understanding of the heart came with the work of William Harvey, and then subsequent to that, where he demonstrated the importance of the heart causing the blood to circulate around the body and how that occurred. And this was important because from then on it's been possible to understand what the heart did, and therefore what over time we needed to improve heart function. Now, the structure of the heart, and this is just a refresher for those who've either seen my previous lectures or looked at this at school, is essentially 2 pumps put into one organ. There's a pump on the left side, which pumps blood around the body, and a pump on the right side that pumps blood through the lungs, and they work simultaneously, and they've both got 2 chambers, an upper chamber, the atrium, and a lower chamber, the ventricle. Now, the important structures within this are a strong and relentless muscle that pumps roughly once every second if you're having to exercise or have other reasons for your heart rate going up more frequently than that, from the moment that before you're born through to the moment you die. It's an extraordinary organ. And then to make sure that the flow from that pump goes in any one direction, there are 4 valves, which actually make sure that the heart goes, the blood goes from the top of the heart to the bottom, from the atrium to the ventricle, and then from the ventricle around the body. And around that is a sac, the pericardial sac, which is a fibrous sac, has a number of functions, but it is important for a number of medical conditions I'll come on to a bit later in the lecture. When it comes to diagnosing the structural problems of the heart, this is really different from the way that we diagnose things in the last 2 lectures. The thing which is in common is that you start off with talking, the doctor or nurse or medical practitioner will talk about symptoms, their timing, and what you're feeling as a patient or what someone you know is feeling as a patient. But physical examination is very important in understanding structural problems with the heart. And this will include the heart size, the pulse, and the blood pressure. And then for valve disease, additionally, doctors will listen with a stethoscope. Now, the creation of the first stethoscope was a major advance. Until then, doctors had to try and listen to the front or back of the chest, just putting their ear against someone's chest. But the first stethoscope was produced back in 1816 and has been steadily improved on ever since then. And one of its principal functions is to give heart sounds, which give information about heart valve function. Additional to this, relatively old technology, plain X-rays that show the size and the shape of the heart, and an ECG. I discussed ECGs at some length in the last lecture when we were talking about rhythms, which can give additional information. So those are kind of the standard older technologies. But the thing which really has transformed our ability to make an accurate diagnosis of heart structures is cardiac ultrasound and Doppler, also often known as echocardiogram. And this does two things. It gives the ultrasound gives a two-dimensional representation of the heart as it is pumping, so you can actually see it pumping, see the size of the the size of the walls of the heart, for example, see which bits are pumping properly, look at the heart valves. And also the Doppler component can look at the flow of blood across valves and pick up other problems. So it can pick up a lot of information. In the great majority of people, this is what's called transthoracic. It's simply a probe put on the chest, and it's completely non-invasive. It has no known side effects at all and gives an extraordinarily detailed view. And on the right here, you can see a picture of the heart. It looks as if it's upside down in the way that it's oriented, and you can see in that very clearly the various structures of the heart. And that's what an echocardiogram is doing if it happens to you or a friend or relative of yours. It is possible for some situations also to look at the heart from the back side by looking into something down the esophagus. Very rarely, people can also use echocardiograms or a version of those actually inside the heart itself, but most of it is done across the chest. This has transformed what we can do, and I'm just going to show this with two illustrations. Here on the left, the coloured area is the Doppler flow, showing a flow of blood, and it shows that there's a flow of blood through from the left side to the right side of the heart, and this is because there's a hole in the heart. It shouldn't be happening under ordinary circumstances. And on the right side, it's showing a vegetation, shown by the little white arrow, on a heart valve from an infection that's sitting on a heart. So you can really see extraordinary detail with this technology. Additionally, we now increasingly use cardiac MRI and cardiac CT, and what's made that possible is being able to do things quickly enough that it can deal with the fact that the heart is beating the whole time. There's no way you can obviously stop the heart. So a combination of echocardiograms and these additional modalities mean we can get a very good understanding of the structure and indeed the functioning of the structure of the heart. I'd like to start off in considering valve disease of the heart, and just going through the valves so you understand what their structures are. They're on the left and the right. They've both got a valve that goes from the atrium to the ventricle, and then another valve that goes from the ventricle to the main body, which makes sure there isn't backflow. On the left side, the one from the atrium to the ventricle is called the mitral valve, and from the ventricle to the body, it's called the aortic valve. The other two valves are less commonly a problem, but they can occasionally cause disease. Now, valves can do one of two things. They can be too narrow, and that means the blood can't flow properly across them, or they can have a regurgitation, which means that they are open, slightly open, or floppy, meaning that blood can flow backwards. And sometimes they can, in fact, be both of those. Now, all four valves can, in principle, be either stenosed, narrow, or regurgitant, allowing blood to flow backwards through them. But in clinical practice, it's really the valves on the left side of the heart which tend to cause the problems. And this pie chart shows that the biggest cause of the deaths from valve heart disease is the aortic valve. That's the valve from the heart into the body. And then the second most common is the mitral valve. Only 15% are from the valves on the right side of the heart, although they can occasionally cause issues. Numerically, the most important cause of this in high-income countries now by far is that people will have increasing degeneration of the heart valves as they go on through life. Now, for many people, this makes no practical difference. So there's a bit of degeneration. It doesn't really cause them any problems over their natural lifespan. But for some, they will go on to have clinically important heart disease. Numerically, the most common cause of this is mitral valves, but remember, aortic is more likely to cause mortality in terms of numbers. And it's made more likely by things like high lipids, hypertension, diabetes or obesity, chronic kidney disease, or smoking. So very similar things to the things that caused an increased risk of coronary heart disease, which I discussed in the first lecture in this series. For those who do have symptoms, so the heart valve problems are causing them issues, and many don't have any at all, symptoms include shortness of breath, doing things that people used to be able to do, and they start noticing that they really get very short of breath. Lots of possible causes for this, but valve problems is certainly one of them. They may have dizziness or fainting, especially when they're exercising in some way. They may have chest pain. They may have fatigue in general, or they may have swelling up of the limbs, so particularly the legs, or the abdomen. Now, all of these have potential other causes, but valve heart disease problems are certainly one of those. So they're definitely things that need to be investigated. The second group of things which can cause problems on the valves of the heart is infection, normally called endocarditis. Generally, this is bacterial infection. Occasionally, it can be fungal. And this is where the infection settles on the heart valve, and it grows there, can cause infection in the rest of the body because it's a source of infection. You can get emboli flicking off, which I'll come on to, and it can cause damage to the heart valve that needs surgery. So they can be really quite serious. The risk factors for this, it's much less common in people whose heart valves are normal, so they tend to be more likely if people have already got abnormal heart valves, maybe artificial valves, congenital heart valve problems, and also if they have problems with the heart muscle. And things which tend to allow the bacteria to cause this tend to be things that doctors, dentists, and others do. So they might include putting intravenous lines in hospital, particularly if they're in someone for a long period of time. People who take intravenous drugs recreationally, often with rather dirty needles. Dentistry, where dentists are doing a minor operation in the mouth, and surgery are all situations where the risk of endocarditis, because bacteria have got into the blood, increases. Now, which bacteria or fungus causes this does depend on the setting. So endocarditis can cause a lot of different issues, and the big ones are that it can have emboli, can cause little growths around the heart valve, and then they flick off, and they can cause problems around the body, but particularly they can cause strokes because the emboli can get into the brain. They can cause a fever and infection in other bits of the body, and as I say, they can cause damage to the heart valve itself. And these can occur with almost any of the organisms, but some, in particular, the organism Staphylococcus, are particularly prone to this. And in hospital, the most common bacteria is Staphylococcus aureus, and it usually gets in through lines or occasionally through surgery. If it's from the mouth, it's a different bacterial group that tends to be more common, a group called Streptococcus viridans group. And if it's from the gut, for example, if someone's got damage to the gut, occasionally has a tumor of the gut, recent surgery, it can be a bacteria called Streptococcus bovis. So where the source of the infection is will determine what the infection might be. And then in people who've got significant immunosuppression, for example, during some forms of chemotherapy, some fungal infections, particularly a relatively common yeast called Candida, can cause issues. When people have got endocarditis, many of them can be treated just with antibiotics, or in the case of fungal infections, antifungals, for a prolonged period of time. And that may be sufficient to treat it, but in a significant minority, they will need to go on to have heart valve surgery. So this is not a trivial infection at all. A separate way by which infections can cause damage to heart valves is a disease cluster called rheumatic heart disease, following on from rheumatic fever. Rheumatic fever follows on from group A streptococcus. And this is used to be very common, still relatively common, infection of the throat or of the skin. And in the majority of cases, it passes off even without treatment, but in a minority of cases, it can cause rheumatic fever. And rheumatic fever has quite a number of really quite striking symptoms. Used to be extremely common in the UK. If you went back in time, to the 1880s, for example, but it was between the second and fourth most common reason that children were admitted to hospital, using the records of Great Ormond Street. So it was a very common issue. It's actually not due to the infection directly, but due to an immunological reaction, and it can have effects on the joints, hence why it's called rheumatic. It can cause neurological problems. Something called St. Vitus's dance can occur, which is, again, very striking to see. And it can damage the heart valves, in particular the mitral valve. And this one used to be one of the most common causes of valve heart disease in the UK, as well as internationally. And this can go on to cause heart failure and the rhythm disturbance I talked about last time, atrial fibrillation. Fortunately, improvements in living conditions and then the advent of antibiotics have led to a very substantial reduction. So this is now extremely rare that people get infections bad enough that they go on to get rheumatic heart disease. So this has really gone down a very long way in high-income settings, although some older people are still living with the effects of rheumatic fever in childhood. But it remains an issue in many low-income settings, in particular where there's a lot of crowding and there's a lack of availability of healthcare. So this is not a problem that's gone away globally, but it is a problem that's much less common than it was, particularly in high-income settings. So several different things can damage the heart valves. If people have got symptoms, but they're relatively manageable symptoms, it may well be possible to control those symptoms with drugs. And the treatment of relatively limited symptoms is the treatment of the symptoms themselves. So there isn't a drug treatment that's going to reverse valve heart disease, with a possible exception of endocarditis in the earlier stages. But you do have a situation where the drugs, particularly diuretic drugs working on the kidney, can help to control some of the symptoms. And key things are to control the rhythm, using drugs like digoxin. Talked about that, those drugs in some detail last time round. Manage blood pressure to keep the blood pressure under control. I talked about that in some detail in the first lecture of this series. And then diuretics working on the kidney to offload fluids. And using drugs, it may be possible for someone with mild or moderate heart disease to live a fairly normal life without further intervention. But in severe cases where people have got bad symptoms, they are likely to need surgery. Now, surgery is a major undertaking. Clearly, you're trying to do surgery in the heart. It's a permanently beating organ, so not straightforward, and an absolutely vital organ. Wherever possible, surgeons now try to repair valves rather than replace them. And that is because you're less likely to have long-term problems as a result of that. The most common situation where surgeons can actually repair is repair to the mitral valve, but it's not always by any means possible. The most minimally invasive form of management is something called balloon valvoplasty, and that's where you put a balloon across the valve and blow it up when there's a narrowing, and that can make the narrowing much less severe. So this is a treatment for stenosis. But in general, although this is a relatively straightforward procedure compared to what I'll go on to, which is major heart surgery, still quite a significant procedure, putting a wire across the valve and blowing up the balloon. It is something which is usually temporary in nature. People usually need to have further procedures done subsequently. But most valve repair and replacement will be a much more major undertaking. And currently, the majority will require what's called open heart surgery. The standard way of either repairing or replacing valves is to do an operation where the breastbone, the sternum, is opened up, exposing the heart underneath it. And then the circulation is put on a bypass machine. So a machine takes over the job that the heart would normally be doing, pumping blood around the lungs and the body. And then the heart is stopped temporarily because it's very difficult, clearly, to do an operation, a really careful operation, whilst the heart is beating. The surgeon repairs or replaces the heart valve, and then the heart is restarted. So this is a really major undertaking. So it's not something that is undertaken lightly. Heart valve replacements have steadily improved over time. We had quite the early heart valve replacements involved, for example, what's called ball and cage valves, where there was literally a ball in a cage, and that was the way that the valve worked. But we've now got a range of tilting discs and different forms of artificial valve, and also valves, fibrous valves, and valves which may come from people who've recently died and generously donated organs, or in some cases from animals. And the pros and cons of these will be discussed with the person who's having the operation by the surgeons. Some are less likely to cause problems in the short term, but may be more likely to wear out in the long term. So a lot of it depends on the age of the person involved, what is the best approach. There are, however, for some situations, less invasive repair or replacement options. Some centres are now doing a less invasive surgery, but same principle in terms of the operations, where people, rather than having their sternum opened up, have multiple cuts to different bits to do a more non-invasive surgery. More commonly, there's a procedure which is used for people who have aortic valve, but which they are not considered to be a good candidate for having a really major surgery with bypass and so on. And this is something called a TAVI procedure. And this is a much smaller procedure where a nick is made in the groin, and then a tube is passed up to the heart valve, and a new valve is fixed over the existing valve. So there isn't a major operation where it's actually replaced, it's a fixing over the top of it. It can be done under local anaesthetic, but it doesn't have the long-term benefits of the major heart surgery, and therefore it's used for people under certain circumstances, but certainly does not replace the need for open heart surgery for many, particularly younger people. So heart surgery leading to valve repair of different sorts and replacement is a very major advance, but it is a relatively high-risk surgery. Many people who would have died or had extremely constrained lives have, as a result of this surgery, now been able to have normal or near normal lives. So it has been, for many people, transformational. There are risks, including stroke during or after the operation, and cardiac bypass has a number of risks itself for short and medium-term effects. So it's not something which is undertaken lightly, but when it happens, it is potentially transformational. The second group of diseases and conditions I'd like to talk about is cardiomyopathy, and this is where the heart muscle is damaged or abnormal in some way, meaning it's not functioning normally. And there are broadly three types. dilated cardiomyopathy, and that's where the heart essentially expands rather like a slightly soggy balloon. Hypertrophic cardiomyopathy, which is largely inherited, and this is when the heart muscle becomes actually too fat, too thick for effective heart beating. And then restrictive cardiomyopathy, where the muscle wall becomes stiff and less able to beat in the normal way. So these are the common ones, of which the most common is dilated cardiomyopathy. So if you think about it, if the heart muscle is not working normally, then the pump is going to work less effectively. And symptoms that people tend to get with cardiomyopathy are shortness of breath, particularly when they're exercising, at least initially, fatigue, dizziness and lightheadedness. Remember, these are quite similar to many of the symptoms I was talking about with valve disease. Swelling of the feet and legs, arrhythmias, so where people's heart rhythm changes unexpectedly, chest pain, and a new heart murmur that might be picked up just as part of a routine medical. So there are a variety of ways it presents, and initially many people have no symptoms at all. The most common cause of dilated cardiomyopathy, in high-income countries at least, is ischemic cardiomyopathy. And this is damage to the heart muscle because it's been short of oxygen. This is most clear when people have had a heart attack and the bit of the muscle wall during the heart attack, because it was starved of oxygen for a long enough period, has actually died. But ischemia is one of the most common causes of cardiomyopathy. This can then in turn lead to what is called heart failure, and I'll talk about heart failure in a few minutes. The prevention of ischemic cardiomyopathy is therefore the same really as the prevention of coronary heart disease. All the things which are good for that, improving exercise, stopping smoking, reducing cholesterol, reducing hypertension, for example, are all part of the things that reduce the chances that someone will go on to get cardiomyopathy. There are a number of other causes of dilated cardiomyopathy. Some drugs and toxins can damage the heart muscle. Alcohol over long periods and at very high quantities can cause dilated cardiomyopathy due to essentially its effects on the muscle, as can cocaine and amphetamines in much shorter period. Some chemotherapy drugs can occasionally do this, and if you're going to be given one of these, this may be something which a doctor discusses with you. And some toxins and chemicals, much less widely used now, at least under much more controlled conditions, such as lead, mercury, and cobalt, can also be associated. So it's not just the ischemic cardiomyopathy that causes dilated cardiomyopathy, but ischemic is the most common. A rare but very important cardiomyopathy is one which occurs during or very shortly after pregnancy. So peripartum cardiomyopathy, as it's called, is rare, but obviously it's very important. It tends to occur late on in a pregnancy or shortly after childbirth. And it needs to be identified and treated early. And the reason for saying that in particular is many of the symptoms that people get, shortness of breath, swelling, they may well ascribe to the fact they're in the late stages of pregnancy. The majority of women who have a peripartum cardiomyopathy will make a complete recovery, but it can be slow. And in a few cases, in some cases, they will have persisting problems. The cause of this is unknown, but it is something which needs to be identified when it occurs. So we now move on to hypertrophic cardiomyopathy, where the heart muscle is very thick. It can occur at any age, but it commonly begins in late teens or early adulthood in terms of people at least noticing symptoms. And it's usually inherited. the number of people who inherit some degree of hypertrophic cardiomyopathy but it's not diagnosed is probably significant. Maybe up to 1 in 500 people have this. But for some people, this is a much more serious problem and causes them serious heart problems. It's inherited autosomally dominant fashion, which means that if one parent has it, it's a roughly 50-50 chance that children have it. So if someone has got medically important hypertrophic cardiomyopathy, the recommendation is that all first-degree blood relatives are screened because there is a reasonable chance that they may also have it. It can cause chronic longer-term problems. It can also occasionally cause sudden deaths, particularly in people who are athletes. But I want to stress this is very rare, and it's about 1 death per 200,000 athletes. So the probability of any individual having this are extremely low. But there is a risk through life, and it needs to be identified, and the risks are reduced because that way there's the optimal chance that people will have a normal lifespan with no major problems from it. The third broad category of cardiomyopathy is restrictive cardiomyopathy. And this is where the heart muscle generally becomes stiff, usually because it has been infiltrated with something that is not muscle. Common things which can cause this, all of them are very rare, but common compared to one another, are hemochromatosis. This is a condition where people have too much iron in the body, sarcoid, amyloid, and connective tissue diseases. So these are, and then some drugs and radiation can also cause problems. So these make the heart muscle more stiff, and therefore it is less effective in its operation. A rather strange form of cardiomyopathy, the cause for which is not really fully understood, and a temporary one, is stress-induced cardiomyopathy, also sometimes called broken heart syndrome. This is where you get, and you can actually see it, it's a physical thing, a sudden myocardial dysfunction where the heart muscle is not working normally after a very stressful event, such as a bereavement or a divorce. People get chest pain, shortness of breath, abnormal heart movements are actually seen, and an abnormal blood test and an ECG. So this is a very physical phenomenon, it's not imagined, and it can cause severe heart dysfunction, but it's usually temporary, days to weeks. And then finally, in terms of the causes of cardiomyopathy, one just to mention, because it is very rare in the UK, but common where it's common, is an infection called Chagas disease, which is a parasitic disease passed on by a kind of bug, rejuvid bugs, which are only found in Latin America, and it infiltrates the heart. The parasite infiltrates the heart and can cause cardiomyopathy over many years. It's very uncommon in the UK, only in people who have lived in endemic areas in Latin America, but it is the commonest cause after ischemic cardiomyopathy in Latin America, but it's getting, fortunately, a lot less common over time. Now, the end result of cardiomyopathy, and particularly ischemic cardiomyopathy, which is the most common, is likely, if it progresses, to be heart failure. Not all heart failure is due to cardiomyopathy. You can get it due to valve disease, you can get it due to ischemic disease, and a number of things can be the cause of it, but cardiomyopathy is one of the most important causes. And it can be from very mild heart failure to severe. So it's not a yes-no, it's a gradual spectrum. And most commonly, people grade it according to the New York Heart Association class, where class 1 is the mildest. People don't get any symptoms during normal physical activity, all the way up to class 4, where people are unable to conduct their ordinary physical activity without discomfort, and they may well have symptoms when they're resting. And severe cardiac failure is extremely debilitating, where people are really unable to do very much at all. Now, within that, people may have cardiomyopathy of the whole heart, or maybe predominantly, at least initially, on the left side of the heart or on the right side, and this also would be true for valvular heart disease. Generally, left heart failure is where there's an accumulation of fluid on the lungs, shown here on the left, where people have problems with shortness of breath, and if you listen to the back of their chest, you can actually hear the fluid in it. And then right heart failure tends to lead to swelling, particularly of the lower limbs, but it can be all the limbs and the abdomen potentially can get swollen because of this. So they can be either or both of these as a result. How to treat heart failure depends on how severe it is. Normally, there is now a test to diagnose it. So I've written it out here. BNP is N-terminal pro-B type BNP, and an echocardiogram. So a blood test and an echocardiogram will usually be used to diagnose it. And the echocardiogram also helps to say, is this a muscle problem or is this a valve problem in particular? The next thing that happens is really going through all the possible risk factors for heart disease to minimize the chance that heart disease is going to progress. So this includes things like blood pressure, smoking, exercise, lipids. All these kind of issues need to be addressed to slow down the likely progression of disease. The drugs which are used as first line in most people who need treatment are two drug classes I talked about in the first lecture of this series, ACE inhibitors and beta blockers. And ACE inhibitor, these two drugs can lead to a significant improvement in symptoms, and then there's a slight variation on the drug class similar to, in some ways, ACE inhibitors, which people can use if they can't tolerate ACE inhibitors due to coughing, which is the most common reason people have to stop it. And they may well need some kind of diuretics called mineralocorticoid receptor antagonists, and a quite well-known drug in this class is something called spironolactone. So these can be used for people with mild or moderate cardiac failure and can significantly improve their symptoms. They're not reversing the process, but they're controlling the symptoms. In more severe cases, however, people may well need a much wider range of drugs, and this tends to be done by specialist clinics. And often it takes a while to get the right combination of drugs. Very often there are side effects, for example, on the kidney, which can very often simultaneously have problems. And so it may take a while to get the particular combination that works best for an individual. It's also going to be important in these more severe cases to get absolutely everything else as good as it can be. And this includes things like making sure that that any rhythm disturbance is treated, went through that in the last lecture, and that any coronary artery problems are dealt with, which I talked about in the first one. So optimizing all other parts of the heart is very important to make sure that the remaining heart, that the muscle that is not damaged or is only partially damaged, can have its best possible function. It's optimizing rhythm and ischemia and all the other risk factors. In very severe cases, and these are rarely done, but are life-saving when they are needed, are left ventricular assist devices. This is a kind of pump, an artificial pump inside the heart, which is usually essentially a holding maneuver whilst waiting for a cardiac transplant. Relatively small numbers of cardiac transplants are undertaken, and they are a very major procedure, clearly, where someone has kindly donated their organs, and their heart can be transferred to someone who's got severe cardiomyopathy, but they need to be a very good match. Now, there are quite a lot of risk factors to this, including that the graft, the new heart, is rejected, that there's graft failure, that things go wrong with it. There's a response to the drug, so there's a lot of risk to this. But in people in whom it's successful, and these days in most cases it is successful, they can go on to have a much improved quality of life over a number of years. So this can be transformational, but is a major condition. And I would encourage anybody who's listening to sign up for organs to be used if they have an accident, for example, because having hearts available for transplant, this could transform someone's life. The next thing to think about with the muscle is when it gets inflamed. This is myocarditis. And inflammation of the heart muscle can be caused by quite a number of reasons, but the most common one is infection. And it's a combination of the infection itself, but often an immunological reaction to that. And to give a sense of the numbers, here in the UK, in 2017, so this is just before the COVID-19 pandemic, about 2,000 hospital admissions occurred in a year. Most people who have this, they have the infection, they have the myocarditis, and then it settles down. So it's an important cause of heart disease in adults and children. Very occasionally it can be associated with sudden deaths, but in most cases people make a full recovery. Viral infections are the most common cause, and I've listed out some of these, including Coxsackie B, parvovirus, HIV, hepatitis, and also, importantly now, COVID-19 is an important cause of myocarditis. There are also some bacteria which can cause this. Ones people may have heard of as things like Legionella. So several infections can cause this inflammation. And the initial inflammation is usually due to the infection, and then there's often a subsequent inflammation due to the body's immune response to that infection. A different kind of infection that used to be extremely important in the UK and globally, much less so now, is the infection diphtheria. And diphtheria is an infection, generally speaking, of the throat or nose, upper airways. But what causes the myocarditis in this case is not an immune response, it's actually the toxin produced by the infection itself. And this can cause heart block, where the heart is not transmitting its impulses properly. And it can cause deaths, and used to cause many deaths in young children in particular. Fortunately, the numbers of diphtheria cases have massively reduced due to a combination initially of reductions in crowding and improvements in antibiotics, and very importantly in vaccination. And childhood vaccination includes diphtheria because this used to be a very major killer of children. There are also non-infectious causes of myocarditis, of this inflammation. Unsurprisingly, these tend to be associated with generalized inflammatory conditions. So people who've got the inflammatory conditions sarcoid or lupus can get myocarditis. Some drugs can do it, and some vaccines can do it. Usually the rates with the vaccine are much lower than the rates with the natural infection. And then some environmental toxins can also do it, but all of these are rare. Important to stress, though, that most cases of myocarditis get better, and in the great majority they're a one-off event, and people recover and after rest and get back to their previous normal lives. So that was the diseases of the heart valves and of the muscle. The third and last structure is the pericardium, or the pericardial sac, and this is the covering of the heart. So here, inflammation of the pericardium, pericardial sac, something called pericarditis, can occur again in association with infections. And it causes chest pain, often in younger people, often sharp pain, stabbing in nature. And people notice that it's worse when they lie down, but made better by sitting up and leaning forward. So the posture they're in will affect how bad it is. If you do an ECG, there are often ECG changes. And the good news with this is that it can be very unpleasant, and very occasionally it can cause significant problems, but in the great majority, it gets better on its own in a few days to a few weeks, occasionally a few months, and just resolves. But in the medium term, in the short term rather, whilst people have got it, they can occasionally get rhythm disturbances, and it can be associated with myocarditis, so the two can occur together. The most common cause of pericarditis is infection again, and two important infections are flu and COVID-19. Other infections, bacterial, fungal, TB, can also do it, as can, rather like with myocarditis, the rheumatoid arthritis and other inflammatory diseases. You can also get this after a heart attack or heart surgery, and a few drugs and vaccines, including COVID-19, but at a much lower rate, generally, than the natural infection. And then blunt trauma to the chest. So if someone has, for example, a major accident, this can sometimes occur. But it usually self-resolves. More dangerous, potentially, is pericardial effusion. So pericardial effusion is when there is fluid in the space between the heart and the pericardial sac. Now, a little bit of pericardial effusion is very common after quite a lot of conditions, including infections, and generally just resolves. People don't actually know about it unless someone looks for it. But there are some important ones which can be life-threatening. The first are where there is hemorrhage into the pericardial sac. So blood hemorrhages, particularly out from either surgery or after a heart attack where the heart muscle is extremely damaged, and it then squeezes the heart because it's basically getting pressure from the outside from the fluid around the heart, pressing on the heart, something called tamponade. And then a slightly slower process can occur where people get a massive heart, and you can see that on the top here. And below that, you can see really the size. The dark grey rather than the white area is the pericardial effusion. And the classical cause of this used to be tuberculosis. And it can squeeze the heart over time, and this is potentially a medical emergency. People sometimes have to actually drain it by putting an emergency needle in to drain off some of the fluid to reduce pressure on the heart. TB can be treated medically. The other causes may need surgery. Then finally, and I want to just cover this very briefly because it's been covered very well and thoroughly in a series of lectures done by Professor Martin Elliott when he was the Gresham Professor of Physics, so they're online and available, is congenital valve and heart structure conditions. Some of these are common, relatively speaking, and relatively minor or self-correct, but some are rare but serious. So just under 1% of births in high-income countries have some degree of congenital heart abnormality, and around 1 in 4 of these, so a quarter of them, are potentially critical. The most common ones are what are colloquially termed as holes in the heart, so ventricular septal defects, so this is when there's a hole between the two sides of the ventricle, or atrial septal defect, when there are holes between the two sides of the atrium. And smaller congenital abnormalities often just improve with time. So they may self-correct early in life or be sufficiently minor they require no intervention at all. There's also one condition, something called patent ductus arteriosus, PA, which can be treated with drugs and will then just often just close. Then for slightly larger holes in the heart, we now have methods for closing them with a relatively minor procedure, where a catheter is put into the heart from the groin or elsewhere, and a closure device, which essentially looks like two parasols. One parasol is put through the hole and then opened and put against the heart, and the other one is put against it the other side. And so it's possible to close these holes with a relatively short and minor procedure. And then some valve abnormalities can be again dealt with via a catheter by, for example, doing a balloon valvoplasty. But a minority of more major conditions, and this is something which Professor Elliott talked about, and I therefore don't want to repeat, will need surgery, and sometimes really very major surgery, which needs to be done in stages, so it can't all be done in one go. So quite a range of possible things can happen as congenital heart valve or heart muscle structure problems. So that's the diseases of the structure of the heart. I've concentrated in particular on valve disease, either too narrow, stenosis, or regurgitant, on valve infections, on cardiomyopathies where the heart muscle is not working, or heart muscle inflammation, myocarditis, and problems of the pericardium, and then finally, but very briefly, congenital heart valve or muscle problems. So there are a range of them, but they're part of the range of things that cause heart disease that I've run through over the course of this year.